And that leads us beautifully onto our final speaker, who I actually came across on Facebook, where he published his, he posted some guidelines that he had published on long COVID. And from getting in contact with him and speaking to him, I also realised that he had suffered from COVID and long COVID himself. So he's going to be giving his insights as a patient and as a doctor, and how this has had an impact on his identity. So I'd like to introduce Dr. Ashish Chaudhry. He's a GP partner and trainer in Salford, and also a university clinical lecturer at the University of Manchester. And his talk is on long COVID, a reluctant pioneer.
Thank you, Layla. Thanks for the introduction. I'm hoping I can share my screen and share content. I'm just going to try this now. Let's just, where's the where's my slideshow? I think that should work. Okay, I think, can you see my slides? Is that come up as a normal slide view there just before I start?
We can also see your next slide and notes.
And notes. How do I change this then? Apologies. Stop presenting. So I want to swap this over, don't I? Yeah, that's not how I want to do it. Neither is that.
There's a display settings.
Display settings, yeah. Yeah, is that better? Yeah. Okay, thank you. Yeah, thanks for the introduction. I'm Ashish. As mentioned, I'm a GP, I'm a clinical lecturer, but also, unfortunately, I suffered with long COVID, and I've been intrigued by the previous lecture because a lot of my insight was from social media, from Facebook groups, from colleagues I collaborated with. So it was real fascinating to hear that. So this isn't intended to be a didactic lecture about long COVID or clinical features, but I wanted to share my thoughts, my feelings, my emotions about what it felt like to suffer with long COVID, a condition that was previously undiagnosed, unknown, doctors didn't really know much about it, but also what it was like to live with that. And I also want to share my reflections on some of my interactions with healthcare professionals on the other side. And I wanted to make this session reflective for you all, and I'm hoping it may end up challenging some of your own assumptions about long COVID and help you be honest with yourselves and your patients. But firstly, what I want to reassure you about as GPs is that whilst long COVID is a new disease, the processes we go through in managing the disease and the uncertainty is not new to us as GPs. Daniel Kahneman, a psychologist, won the Nobel Prize for Economics a few years ago, and in his book Thinking Fast and Slow, he talked about dual processing theory, which many of you will probably be aware of. You've got type 1 and type 2 systems. Type 1 is instinctive, recognizable pattern recognition, such as a patient with pleuritic chest pain, is a smoker, presents with a swollen leg, and you think this is a PE, and you send them off to the big white building to be looked at. Type 2 processing is new, it's effortful. We don't know the disease processes, we don't know the etiology, we can't make sense of it. And we need to work through it, we take our time. And unfortunately, long COVID patients take time because the patterns are not instantly recognizable. Although they are emerging, and we are now a year and a half, almost 2 years on from the first wave of the pandemic, we're starting to develop those patterns: microemboli, fibrosis, myocarditis, and these things are still rare, but becoming more and more in our vision. This is me pre-COVID, around 2 years ago. I was fit, active, 39-year-old, healthy GP with no pre-existing conditions. I acquired COVID in March 2020, started with a cough, thought nothing of it. And if you remember, I mean, these were the days before vaccination, before testing was widely available. So there's a great deal more uncertainty about what this disease actually meant. But as we were learning about the effects of acute COVID from our colleagues in Southeast Asia, in Italy, Lombardy was going into crisis. You know, in the UK, we were still playing football against other countries. We were still going to the horse races. We were still carrying on as normal. Our government was a little bit slow to lock down at that time and recognise the potential impact this could be. Now, I don't know where I got it from. It could have been a Good Samaritan act. I went to see a neighbour who had a flu-like illness when her husband knocked on my door and said, "Can you come and see her? She doesn't want to go to hospital." And I was caught unawares, didn't have any PPE, but just grabbed my doctor's bag and went over and convinced her to go to hospital. It might have been a patient at work, and again, when we weren't properly using PPE, or it could have been that I attended the Manchester Derby a couple of weeks before lockdown. But I developed a cough, I isolated, and I worked from home. And as I mentioned, swabs were really hard to come by. Luckily, by chance, I received an email around 20 days after my cough had started from the CCG, and they had access to 10 swabs in the greater Manchester area. And I thought, well, please can I have one? And luckily I was able to go and get swabbed at the airport. This came back indeterminate. So I'm like, I've got this cough, do I carry on isolating? I'm not really sure what's going on. I feel okay at this stage. But the result advised me to get another swab. And again, that happened at day 27, which came back positive. I didn't really know how to interpret this, neither did my colleagues who I was speaking to or my GPs. However, a positive swab was key to further management because it helped me to validate my symptoms. And this is something which many medics in the long COVID online groups have found it very hard to get that validation from their colleagues because they haven't had a positive swab at the time of initial illness. So over the coming weeks, I started noticing I was getting breathless in between my 2 swab tests. I started monitoring my SATs, being a medical patient, and I noticed I was tacky. 120 to 150 on minimal exertion. My SATs monitor was reading 90 to 95. And as days went by, I noticed my exercise tolerance reducing. My tachycardia was on minimal exertion, going upstairs, having a shower. And I thought, this isn't quite right. So, and I was telephone consulting at the time. And I started developing this very strange pain in my neck and shortness of breath whilst talking. No, I couldn't really interpret it, but shortness of breath at rest and on talking, you know, I'm thinking back to my own medical experience and I'm thinking, well, this person is probably more breathless than they should be. So I spoke to my GP 3 times over the phone and was told not to worry about it. It was virus, and he was abrupt, fairly short with me, didn't really explore any of my concerns or expectations or ideas. And I asked him about my tachycardia, and he really couldn't give me an explanation, but just said, don't worry about it. I was hoping he'd ask me whether I wanted some bloods, an ECG, maybe. And what I really wanted was somebody to make a decision based on evidence and not just a hunch over the telephone that we were dealing with nothing that I should be worried about. Now, you know, reflecting on my medical interactions, I recognise that myself included, many GPs were new to telephone consulting. Remote assessment was very much a type 2 process, effortful, hard, exhausting. Finally, he agreed for me to be seen in a hot tub at around 4 weeks. Now, I don't understand why it took him 3 interactions to refer me, but I'll come back to this shortly. At 4 weeks, I felt I should be feeling better, but I unusually was still febrile, still a bit tacky. And although my SATs were fine at rest, and going upstairs, I was desaturating. The doctor in the hot hub, again, fully gowned and masked, told me, go home and rest, your chest is clear, you've got a slight temperature. And I said, well, what about the tachy? He said, no, this is all virus, go home. And I said to him, do I need an x-ray? And he said, no, you don't want to go to hospital. You don't need intubating. Just stay at home and rest. He didn't really give me the opportunity to ask questions. I was sort of ferried out of the room because there was another person waiting, and it was all on very specific time slots at the hot hub at the time. So eventually I lost my nerve and I went to A&E at week 5. I've been reading lots about the effects of acute COVID over the last few weeks. I found a Facebook doctors group and the numbers were growing. There were around 1,000 doctors currently, but at the time there was around 100 of us. And we started sharing medical literature from around the world. And I felt, and we all felt, that the medics we were speaking to were unaware of the possibilities of complications that were potential here. And the government was still saying it's a mild self-limiting illness. And this is what we as doctors and doctors in my own practice were following. We were using tools like the Roth score, which I don't know if you'll remember. This was when you had to hold your breath and then take a big breath in and count to 30 within a certain period of time. And if you couldn't count to 30, then that might have been an indicator of some degree of respiratory distress. But this was later disputed and not validated. So we stopped using that. But medics and patients were trying to find their way through this. Anyway, going back to my A&E encounter, I was assessed by a very kind A&P. My perception was, finally, somebody's listening to me. And he listened and he considered possibilities. And I shared with him what I'd read. And I was diagnosed with a viral pneumonia and had a series of tests as well, including a D-dimer and a troponin. And we were still learning about microemboli and myocarditis, about acute COVID. And I just felt that he was exploring these options and he spoke to his consultant about them. Time went by and I bought that diagnosis, viral pneumonia, and luckily I went home and rested, but at week 8 I was still no better. And I thought, what's going on here? Why am I still breathless? Pneumonias, in my experience, last 4 to 6 weeks and I'm fit and healthy, so should really be getting better. And I just wanted to sort of express my frustration here, so I sought a private opinion. This was expensive, but I had 30 minutes to share what I wanted to share, and it provided validation. The consultant recognised that I was worried about PEs and fibrosis, and although the HRCT cost me £500 and burnt a hole in my pocket, I was reassured, and something which I hadn't received from the NHS so far. Now, there was no fibrosis or myocarditis, but of course we know we're not picking up all these cases on echo now, and some of them are only being picked up by cardiac MR. That's not widely available. But my most persistent symptom, and symptom I'm still struggling with 2 years later, is pain in my neck and pain on talking after prolonged periods of time. So I had to arrange for other ways to get that help. And a friend of mine who's an ENT surgeon arranged for me to see one of his colleagues locally who arranged a laryngoscopy, and I was diagnosed with a condition called muscle tension dysphonia. And because of the limitations in resources and because I'd lost faith in the NHS and my own GP, I accessed speech and language therapy over Zoom. And I was off work for 3 or 4 months with brain fog, shortness of breath, tachycardia, fatigue, and also COVID overload. So I had 8 healthcare encounters in 3 months, and I've asked myself repeatedly, because I'm a medical educator as well, and I'd like to look back on my experience as a learning curve for myself, an opportunity to teach others, is were they effective? And in this talk, I wanted to take the slant of, what were the challenges to effective patient consultations and interactions during the pandemic, and particularly during the first phase? Well, firstly, there's the disease itself. COVID, it was contagious. Doctors had fears. We had lack of PPE, the face-to-face appointment system was changing, we were telephone consulting, and we didn't really know where we stood as doctors. The evidence was sketchy. It was advice, anecdotal. We didn't have guidance. Referral pathways weren't widely known, so doctors really didn't know what to do with these patients. And short of telling people they'll be okay and hopefully buying time, this was the strategy that seemed to be employed. Remote consulting, it's a new skill, it's not everybody's forte. Some people found it beneficial, some people hate it. Yes, it's convenient, but you don't see a patient. So what are we missing? Not just in terms of disease, but in terms of rapport, in terms of connection with our patients. And are we able to build trust remotely? Voices and names, my registrars tell me when they speak to a mental health, a patient with mental health problems, all seem to merge into one story because they don't recognize the face of the person they're talking to. I want to talk about bias. Being labelled as having anxiety is always a dangerous game, and a lot of doctors, as alluded to in the previous presentation, felt that they were gaslighted, not believed for the symptoms that they were having. You know, how could this possibly be due to COVID, as was alluded to? And that's a very common theme that I've come across as well. So how did we as doctors perceive COVID, or long COVID for that matter, you know, and where were we getting that education, that information in order to process this new disease? Was it from the news? Was it anecdotally? And there was a growing subset of patients developing long COVID. Were their voices being heard? And it made me reflect that there's a risk of labelling other medically unexplained symptoms in the same boat: chronic Lyme's, chronic fatigue syndrome, ME. And I know as a doctor prior to COVID, I've done the same, those heart sink patients. And just because we don't understand why those symptoms exist, medical science doesn't provide the answers, you know, we're at a loss. And I just feel now, having come through this, maybe there's a different way to support these patients, especially when their tests are negative. But finally, there's demands and expectations of patients which were rising, which makes it very, very difficult for GPs to give their best. Initially, what was touted as a technological revolution in the NHS, in primary care, in some ways has led to more burnout. And finally, vulnerability. And vulnerability is really important. And I've dedicated a whole slide to this because I think it's so crucial. Both doctors have felt vulnerable in the pandemic in terms of not knowing anything about long COVID, carrying increased risk, trying to balance doing no harm versus beneficence, and trying to apply justice to all their patients and manage resources and get through as many people as possible on the phone. But on the other side, the fear of catching COVID from patients. And at least, you know, when I'm consulting again now, I can't help but admit that on a subconscious level, I'm scared of catching this again. And is it impacting on the way I manage my patients? Am I less reluctant to bring them in face to face when they could be asymptomatic carriers? For a patient, however, I felt my vulnerability was enhanced. We teach our trainees about the importance of ICE, and I always teach them that patients present for two reasons. Their concerns are either related to the disease itself, or related to the effects of the disease on their function. So I was worried about, will I be able to carry on being a doctor, and how will it affect my family life? So I went through a whole range of emotions regarding my healthcare encounters, from a feeling of being unfairly treated, not listened to, gaslighted, anger at the system, rejection, bargaining, and a whole load of swear words as well. But as a medical patient, I had deeply formed ideas, concerns, and expectations. Very challenging for my own GP, no doubt, but I just wanted to be heard and be treated as an adult, and be listened to. And it required a lot of courage for me to speak again and again and again. And I felt at various times a lack of connection and a lack of compassion. So to conclude, when you're assessing your patients, it's really important to consider the effects of COVID on their lives, their concerns about their illness. It's still a new disease. Patterns are emerging, theories are emerging, POTS, MCAS, venous thromboemboli. I mean, how can this be related to a mild respiratory illness that we were initially being told about? So the investigation, the assessment, the management has to be coordinated with rehabilitation, but also hope, and taking on board the patient's pre-existing status. I consider myself to be a highly functioning individual in most ways, but I was significantly disabled for a good part of 2020. And my final point, just a point about anxiety, and with any chronic disease, anxiety is common, but many patients have been waiting a very long time for answers for treatment. And so, you know, my advice would be to my trainees, to anybody I'm speaking to about long COVID, is treat the underlying medical problems as you normally would, but also be aware that anxiety can coexist and isn't necessarily the driver of their issue. Don't label as anxiety until you've ruled out physical disease. So for me, I'd experienced many of the emotions in this diagram with great fear of the future for times. I'm much improved. I'm much better than I was 18 months ago, 2 years ago, but I'm still not doing the same amount of exercise. My voice still tires, and I know when I've done too much. And sadly, I mean, when I log on to Facebook and the long COVID groups, I still hear of patients who are still struggling, but my hope is that they will at some point get better. Thank you very much.
Thank you so much, Ashish. Sorry, just a little bit of feedback. No, I think that's okay. I think that was a really important way to bring the conference to a close, and I really appreciate your honesty with sharing your story.